everybody. Welcome to our next episode of Public Health One-on-One. And today we have with us Dr. Sona. She's an endocrinologist currently working in Kerala. She has immense experience in healthcare, clinical work. And today we are going to discuss a very important public health issue with her, which has just come up in the past few years, which is the issue of overdiagnosis. And wherever we go right now, we are seeing these advertisements for master checkup. We are constantly bombarded with messages asking us to do these checkups at a free, lesser cost. And so that really brings up this problem of overdiagnosis. So before we get started, Sona ma'am, I would just like you to sort of introduce yourself in your own words and tell us, your background and your interests.
Okay. I sort of have grown up all over India. I was born in Kerala, incidentally at the very hospital I work today. And then I grew up for about 9 years in Calcutta. Then I was in Delhi for about 9 years. And then I did my med school from Trivandrum, Government Medical College Trivandrum. Then I went on to do my residency in the US and fellowship in endocrinology there. And I did want to sort of come back to India because somehow I just never felt at home abroad. So that was one of the reasons I moved back. Teaching has been something which I've been passionate about, and in part of being in my practice, I've always been active with my DNB program to kind of I wanted that mix of being in clinical practice and be able to do more clinical teaching. So that is kind of the combination that I've strived to achieve over time. So yeah, and having connected with you on Twitter, I felt that this was something which definitely is an important topic to talk about, because this is something we see about so much today, especially in India, rather. So I think it's a good topic to have a discussion on.
So over the past few years, I'm sure you have been working. You have worked in different parts of the country, different countries as well. What kind of trend have you noticed related to this sort of master checkup trend in India, abroad?
See, the thing is, at least having worked and trained in the US, it's the concept of going to a healthcare provider. You typically have a primary healthcare provider who sees you, who talks to you. You are asked to meet them once a year, and ideally in the past they were probably the GPs or the family medicine people who have a good sense of who you are in the community, the family, everything. So they have a good sense of who you are as a person, what you do, not just you as a point A or B. And then based on that and based on your symptoms, they would suggest a set of tests to you based on your age, based on whatever screening is appropriate for you. It would be sort of more of a targeted screening. Having moved back to India, it's been about close to 15 years, and I think over these years, what has happened in India has been this rise of probably the corporate hospital trend, and I think that is probably what has started this trend of this checkup. And I don't know about the right or wrong of it. There are some pluses, a lot of minuses too, but I think it's probably a way to drive in the business, have people get through the system, and yes, you would sort of diagnose something, and then it's sort of a feeder for the rest of maybe the specialties or whatever. So maybe conceptually it might have been a good idea, but I think the problem, and in some ways, if you look at it, if we can diagnose disease at its very early stages, if we can catch risk factors early, like hypertension, diabetes, at least these two primary silent killers, then we stand in a good way to kind of prevent cardiovascular disease, prevent nephropathy, prevent retinopathy, prevent amputations. So a lot of those things in intention seem good. But then we end up with all these incidentalomas that we pick up, leads to unnecessary endoscopies, scannings, CTs, radiation exposure, a lot of invasive, non-invasive further procedures, and sometimes the patient ends up shelling far more. And it's not just the money; it's the mental agony that a lot of patients go through, because nobody likes to see anything in red on their lab report, or anything amiss on their I mean, for us as a doctor it might be a very subtle thing, but for the patient it sometimes gives them sleepless nights. So I think, as I said, the intention may be a good intention, but I think how it ends up being done and how it's being done today, it's more like a cash cow today, is what I'm starting to feel. And see, if you look at, even in India, if you look at, say, the government's hospital setup, or the rural healthcare system, you would have patients who are presenting with much more florid disease, most what pretty much what we learned in our textbooks. Our textbooks typically don't have these kind of what we see in a health checkup kind of patient. We are seeing most of the, we don't have those classical hypothyroid patients anymore, because we are picking up TSHs of say 5.5 who pretty much are asymptomatic. But yes, if I was to, go on the street and ask anybody, are you tired? Are you losing hair? Are you exhausted? Are you fatigued? Everybody's answer might be a yes. That doesn't mean that they have a thyroid disease. But people come with this 5.5 TSH, anticipating that once you fix this, they're going to be okay. Or people are gaining weight. The first thing in their mind is, oh, it's thyroid. So that's what ends up with the repeated testing. So hospitals on one side, that's one thing. The same issue is with the labs that have propagated and multiplied like anything. So to feed, how things are, I think there's a lot of like a fear mongering, and see, at the end of the day, certain things caught early make sense. We can do something about it. Certain things you can catch them early. I have had patients who've had health checkups for 3 years, and they know they are, say, borderline diabetic. They can see their diabetes evolving, and they've done nothing about it. So what is the, I mean, there are people who take an action about it, and there are people who do it just for the sake of it. But it's not leading to, I mean, where are we headed with all this? And I think, coming to the thing that was kind of causing a little bit of debate recently, is the whole cardiac checkup. And I think that is something, again, with, a few of the experts in the area starting to mention about CT angiograms and things like that, which makes not much sense in a public health setup. And I think we are not targeting the primordial, the primary, and the secondary things, and we're jumping straight to that. I mean, yes, we can do so much in the earlier phase of things. And in an asymptomatic patient who is otherwise comfortable, and you do an angio and you find a 60% block, what then? I mean, what are we going to do? But you're not going to put a stent in. You're going to give them a risk factor modification. You may give them an aspirin. You may give them a statin. But other than that, you're not going to do anything with that. So that's the whole take on how this whole thing plays up. That intent being good, but probably how it is turning out may or may not serve the purpose it started out with.
Yeah, like you mentioned, the execution is actually the whole problem, where and the intent also, I'm not so sure, because it's mostly these it's not health professionals that have made these master checkup plans that get an LFT.
Absolutely. It's the marketing guys who are designing, okay, I need to get this machine. I've invested so much in this
Yeah.
machine, and that needs to, get so much throughput. And so that's unfortunately determines how the packages are made and costed and stuff like that. So, and I think the whole point which I feel in India, which is a little bit of also an issue, is, see, a patient who goes to the doctor, okay, doesn't value the doctor's time and attention. To pay 200 rupees extra for that doctor's consultation, people would feel that the doctor is out to get them. But they would coolly go and blow 10,000 rupees on, say, investigations and things like that without batting an eyelid, and one thing leads to another.
Yeah.
But they don't invest in that much time that the doctor hears them out, goes through all these tests, explains what is the implication. And I think that has made India a very volume based practice,
Mhm.
unlike anywhere else in the world. So I think, I mean, US is different from the UK or Canada for that matter, but still, that pathway of reaching a specialist
Mhm.
is through a certain system. You just don't hear everybody get something, goes straight to the cardiologist, neurologist, wherever specialist. And I think that whole system, and what happens in India is there's like the seniority concept. The senior guy just packs all the patient. There are lots of juniors, so there's unnecessary crowding, and there are, I mean, we could do a lot better in terms of distributing care. It just comes back to how it's a lot of mentality, a lot of things that have to change, which is sort of very deep rooted, and I don't know where to begin.
Yeah. No, but like you rightly mentioned, an investigation without reason to do it makes no sense. For example, I get a lot of these blood reports from my relatives, which will say, sodium is 132. And they'll be totally fine, no complaints, nothing else, but they'll be like, okay, it's coming in bold in my report, so there's an
Exactly,
issue.
exactly.
Or some WBC count being plus minus one, and they'll freak out that there's something abnormal.
That is
So
that is still understandable. I have reports which labs put together of this comprehensive total checkups where they run estrogens and testosterone for all male and female. And the men are like, my estradiol is low. I'm like, yes, dude, that's what it's supposed to be.
yeah.
So that's the problem with, when nobody is there to walk you through what you're finding. We
Yeah.
end up panicking that something's really amiss.
And all as always, the first thing you Google it with the hyponatremia or low sodium, the first option going to pop up
N
is going to
number
be
of
something
cancer.
cancer. Yeah, so that's another huge issue.
Yeah.
And just to before we get into discussing specific diseases, assuming if my uncle who's 60 years old needs a
Hmm.
checkup, or say my brother needs a checkup, so like what is the ideal timing? At what age you should start thinking of regular checkups, or what is the ideal set of investigations one needs at what frequency?
Okay. See, the thing is, I think if we were to sort of asymptomatic sort of patients, if we were to kind of put that in sort of roughly two buckets, I would say one is the big ones are lifestyle disorders,
Hmm.
and the other are the cancers, where the screening protocols are established. A lot of the screening protocols are really established for the Western countries. I'm not sure. I mean, maybe an oncologist would be the best person. As far as lifestyle disorders are concerned, we are starting to see a really early onset of lifestyle disorders, be it diabetes, type 2 diabetes, be it hypertension, be it dyslipidemia, be it coronary artery disease. So it's starting to get really bad. Especially, say, for example, if we were to really look at a metabolic profile, in, say, somebody as young as 10 years old, we might start seeing the beginnings of metabolic dysfunction. Now the thing is, that doesn't mean I'm going to put them on any medications just then. I'm still going to go back and insist on lifestyle changes. So I think schools are starting to wake up to the fact that when we were kids, I remember back in school we used to have once a year height, weight checkup, a dental checkup, and all that stuff.
Hmm.
So I believe that if the schools actually maintain a growth chart of every child, and that's as simple, just as a height and weight, maybe every 6 months or a year, and you see a child is crossing centiles, on weight centiles especially, we know we are starting to get into trouble without any expensive investigations whatsoever. And that is something which is so easy to do, and that data can be captured, maybe done electronically, whatever, maybe, and that could also generate lots of data to study how popular this can be done anywhere, rural, urban, anywhere. We can see trends across India,
Yeah.
and we could just have a cloud platform that sources all these things together. So the earliest is just a height and weight measure, maybe including a waist circumference, because as Indians, we may look lean, but kids too, they may have visceral obesity, and that could be the first sign of insulin resistance, and like increased risk for cardiovascular disease down the road. So that could be probably the simplest, earliest thing that we can see. Everything else can really be done on a more symptomatic basis. Like, so if you have a young girl who's having irregular cycles, okay, then maybe we move on to the next layer of testing in terms of, does she have a thyroid problem? Does she have this? So just the fact that, your growth stunting changes, you can pick up so many things, and that can lead to an appropriate referral, be evaluated, and then do the targeted testing in that group. But again, the same thing. So the minimum things we can do to screen that the younger crowd, maybe a college going, school going, whatever, is maybe a fasting sugar, and checking a blood pressure, and maybe a lipid profile, to start with, the simplest things. Probably there, if we were to do an ultrasound on pretty much every child in that 15 to 20-year bracket, we might actually find a significant proportion of them with stage 1 fatty liver disease. Not to minimize that, but I'm just saying is that it's become so common to the point that nobody bats an eyelid anymore.
Yeah.
So, but then what do we do about it? We know it is lifestyle induced. Then why don't we fix the lifestyle before putting them on 10 medications? So I think that is where I think, what's the point of telling people and sticking a label that I have patients hypertension, we call metabolic syndrome individually, little hypertension, little this, little that, little 5 medications, or you lose weight and we fix all these things.
Yeah.
So that is where I feel the simplest thing would be. And the rest is really what we need is targeted thing. If anything else comes which is making the patient symptomatic in any way, then I think whatever is the symptom based investigation of choice should be the way to go. So, and as far as the cancers, I mean, it really would come to again a regional and age based probability kind of screening that can be done, because cost is also something, and the whole point of early screening and early detection is that we can avoid the big costs down the road. A stitch in time saves 9 is really the logic of why we should be doing something. So and until we are going to take action on something, I don't see what's the point of spending all that money.
Yeah.
So that's how I would look at it.
So, like you mentioned, for kids it should be height, weight, waist circumference, basic thing. But for adults, maybe get a fasting sugar.
Now, that being said, the one thing which we might still miss out is, there is really no real nice way to measure insulin resistance. And even if your fasting sugar is 80, you might be on your way to developing insulin resistance. And a lot of youngsters come with acanthosis, with pigmentation, blackish discoloration of their neck and armpits and stuff like that, the earliest sign of, but then again, it's these are clinical signs which you can pick up. But even before that, and we are starting to understand that probably there is this endothelial inflammation that is being caused by this hyperinsulinemic states, which might be a driver for atherosclerosis, which might be a driver for late disease, because we are that even in subsets who are not diabetic, they are coming up with cardiovascular disease, and maybe we are really missing this thing because we don't have a good test, because
Mm.
there's no standardized way. We can look at the HOMA IR, which is like glucose to an insulin ratio, but these are not standardized, so
Mm.
because of which we can't. But that's why I said that these are the other surrogate measures which are cheap, which we can do and which we can apply to a bigger population at scale.
But ultimately, everything comes down to preventive medicine. At that
Absolutely, it
stage.
does. It does. A lot of things can be done, and I think the burden of healthcare. I mean, you can't prevent a hernia. Maybe. I mean, there are probably things you can do once you know you have a hernia, but there are a lot of things. Maybe at least 50%, I'm sure, of problems can be solved by right preventative measures. Even when it comes to infectious disease, I think we can do a lot of things differently. Maybe even by changing these disorders, maybe we might even be able to change the cardiovascular disease and cancer pathways too. We don't know. I mean, we've not seen that far ahead, but maybe we might be able to do that in a more sustainable fashion.
Yeah. And, this sort of reminds me of something one of my seniors told me. He told me like he has recently come across this new drug which can delay aging. It improves your concentration.
Mhm.
It makes you lose weight.
Mhm.
It makes you happy. And it's called exercise. So, so we know all this, but just taking a pill is something we would prefer rather than
Absolutely,
putting in the hard
absolutely.
work.
See, I have started to see the increasing trend again in younger India. Is most people do really not want to take a medicine if they can help it, because they don't want to be on medicines for life. Understandable so. At 20, nobody likes to hear a diagnosis of diabetes or hypertension and stuff. So a lot of these apps are coming out with fitness and having a coach and stuff like that. Diet, very focused. See, all this is great, but the problem is you are automatically selecting out the motivated patient,
Yeah.
because it was because the patient is willing, they paid that much money,
Hmm.
and they are now willing to put in the exercise. You can't just pay money and not do nothing and expect
Yeah.
nothing magic to happen. But the patient who comes to the doctor is like, well, I don't have time for exercise, I love food, so doc, give me some medicine, do some magic, but just fix me.
Yeah.
So that is a real problem. You Somebody goes to say an Ayurvedic practitioner, he says, "Don't eat any of this." He religiously follows. But when a modern medicine doctor says, "Oh, the pill should take care of everything." No, I mean, especially in lifestyle disorder, the pill can do only so much.
Yeah.
So
And that this is just a general trend, like even in doctors, how often do doctors exercise?
absolutely, and I think one thing about social media is, I think doctors can inspire.
Hmm.
Because a lot of patients ask me, "Doc, what do you eat? Doc, what is your routine like?" So I tell them, "Look, this is my routine. I don't have any help at home. I try to do all my work myself. I try to have two boys. I try to get them involved in my housework so that they learn early. I
Hmm.
talk to them about food choices. I talk to them
Hmm.
about health. So they come, they swim while I am on the treadmill. So
Hmm.
we try to do this as a family, because I can't influence. I can't tell them, do this, don't do that, you're not eating this. They'll have to make these choices for themselves,
Yeah.
and that is what I tell my patients too. It starts with you.
Hmm.
So it's sometimes easier to do it as a family than doing it alone. And all I'm asking you, it's not like a diabetic thing, or it's just a healthier way to live. That's it. I mean, anybody should be doing that. So
So coming back to the general things, one person should do, like just to summarize it, maybe a fasting blood sugar, blood pressure, which is something, in my personal practice, I have not seen many doctors measure blood pressure for
I
everybody who
do.
comes in.
I make sure
Yeah,
I do.
I have seen
So
it a very few number of times. Like not every doctor that I've seen does it. Maybe because it's the patient load
no,
and
I think it's true, but I'm just saying is, I think these are simple things which maybe
Mhm.
you can outsource. So before I start seeing a patient, I want a blood pressure, a weight, and
Yeah.
a height, weight. And because these are simple things that can be done.
Yeah.
So immediately I have a mental model, what I'm thinking, where I'm going to intervene, what is my focus going to be, what kind of medicines I want to think about, what am I looking at. So I think just this simple thing, if we can do, maybe the doctor doesn't have to do it, whoever is, getting the patient into the clinic can do those things. So
Yeah. So basic things like BP and maybe once in a while, maybe annually, how much do you suggest lipid profile? How frequently?
I usually, once I check a lipid profile and say somebody's on, say, a lifestyle modification or, or a medication, I may check it in 3 months just to see how things are. If things are fine, I may tell them I'll probably check it 6 months later. Or if things are really stable, I might, unless their weight or something has changed drastically, I may check it in another year from now.
Okay.
So, because again, I think a lot of it really comes down to cost of care. And it might change from practice to practice. Say in a country like the US or the UK, where somebody else is paying for that, things might be different when the patient pays out of pocket, and the subset of the patients I might see might really be very, cost sensitive. So a lot of my patients actually, go to say Jan Aushadhi or all that for their medication. So I would like to be choosy with what investigation. I might say next visit, just do this. I'll follow up at the next visit. Somebody who doesn't have a problem with getting those investigations done, maybe you can do it at a little slightly more frequent intervals. But that's how I would space it out.
And another sort of doubt to clarify for the non-medicals that, lipid profile, usually some of my relatives have sent me, my HDL is very high. And, it they sort of take it as it's something bad, or HDL being low
Right,
being good,
right.
which is the opposite thing in actually the lipid.
Correct, correct. So your HDL is really our good cholesterol. LDL has historically been our primary target from a cardiovascular disease. So LDL being the bad cholesterol. Triglyceride is something which we haven't paid as much uh, hard attention to, I would say, but it is actually something that is more linked to insulin resistance. So a high triglyceride and a low HDL is probably something which is also very important risk factor for heart disease. So instead of just simply looking at the LDL and bringing that down, improving your HDL by exercise, because that's really the only real thing that will help with improving with the HDL. Some of it is genetics, but as far as the triglycerides, definitely the intake of carbohydrates, sugars, insulin resistance definitely plays a role in the triglycerides. So that also is something that needs to be addressed.
And now coming to this huge issue of hypothyroidism, when every other person, the first thing they do is a thyroid TSH test. And one issue I have realized is that it's there are two ends of the spectrum. People getting overdiagnosed and diagnosed but not being treated adequately. I've seen both the ends.
Absolutely.
So how often do you see this in your practice?
Very often. So, because again, as I said, be it I have thyroid functions ordered by patients themselves, ordered by primary cares, or ordered by homeopaths, ordered by Ayurveds. I have all sorts of patterns, including an anti-TPO antibody by the time they come and see me. They have a T3, T4, the whole, and an ultrasound sometimes. And then they're usually in a panic state by the time they're there. And when I look at the TSH and it's like 5.4, which is just a wedge above normal, I know this is going to take me 10-15 minutes to just tell them I don't need to start any major medications. I'm going to sit and watch how this evolves. So it is really very common because people have this misconception that when you gain a lot of weight, it is because of the thyroid. Now, yes, hypothyroidism can cause weight gain, but usually it is not more than say 2 to 3 kgs at best. A lot of it is water retention. Then that's the only way that will go once you start treating the hypothyroidism. People say, Doc, I'm taking the thyroid medicine, but my weight is just the same. That's because it was never that to start with. The only hormonal condition which can really cause massive weight gain, 10 kgs, 15 kgs, the suspicion to have at the back of your mind is Cushing's. That being said, that's really rare. And you really want to look at the whole patient, take a weight history, see how it's evolved to decide whether to jump in and do that investigation or not. So, as far as the thyroid tests are concerned, again, the TSH is something. So, hyperthyroidism being the smaller subset of the patients, it's usually very real, and when they present. But the hypothyroid is where there is a lot of even differences in how people end up getting treated, because say gynecologists would jump in and start medications, or many people are already on medication sometimes by the time they come and see you, and they're on 12.5 for the last 5 years, which is really microscopic doses. I don't know whether it's really adding any major benefit. And that mental stress that I'm a hypothyroid patient and everything else gets blamed on hypothyroidism. So I think the guidelines are really kind of starting to be really clear that if your TSH is over 10, that's when we would really treat everybody. I think that's sort of more of a consensus. Anything which is sort of between that 5 to 10 is sort of the gray zone. And the older you get, that's still less needed to be, that aggressive. Say a 70, 80-year-old man with a TSH of 7.5, you might as well, just watch and see how it goes. So the biggest issue of not treating is it progressing to overt hypothyroidism. So as long as you're watching, when it is, when it's rising, and then or patient is developing symptoms, and then at that point of time you can intervene. But I think as long as your TSH is say 6 for the last 5 years, unless now you are in a very young patient, you're having issues with fertility, you're having miscarriages, irregular cycles, yes, maybe that's the subset of patients you would want to go ahead and treat and maybe target a slightly lower normal TSH. So you would have to kind of fine tune that requirement and not have a blanket, just treat the TSH kind of approach for everything.
And so if my TSH was 7 today, when is the next time that I should get it checked?
So usually what I do is, so the thing about TSHs is it takes about 6 to 8 weeks for whatever to stabilize. Sometimes, rarely, people have had subclinical thyroiditis, which is a mild low-grade inflammation of the thyroid. And during the recovery phase, they may have a transient hypothyroidism, and that may go away spontaneously. They may go back to normal in maybe 6 to 8 weeks. So a lot of patients are a little reluctant. Now, what I tell them is, see, this is the thing. If you're not very symptomatic today and you incidentally happen to see this TSH, then you were not very worried about this in the outset. So let's do one thing. Before we decide you need to be on medicines lifelong, let's wait for maybe a month or 2 months if you're okay, and get a TSH along with, then we can do an anti-TPO antibody. And that is also, the anti-TPO is really for convincing the patient, not because I need it, but it's sort of more for the patient satisfaction. But if the TSH is stuck there, again, no rush to treat unless in the select subgroups. If it is trending up, yes, maybe we can go ahead and treat. If it is gone back to normal, then probably we'll still maybe tell them once in 6 months, just check if it's fine. Again, going back to family history, whether they have a goiter on my clinical exam, all those would put this patient a little higher in my bucket for clinical suspicion for need of follow-up.
Yeah. And another common thing I've noticed in the PHC I work at is people usually come and say hyper hai, because they'll see the TSH being high.
Yes. No, because many people don't understand that the high TSH is sort of reflection of the fact that your body's thyroid hormone is low. So I usually start with a little class on thyroid, and I tell them your thyroid gland actually makes this T3 and T4 hormones. And when the T3 and T4 are sort of, say, so simplicity's sake, you need a bucket of hormone every day, and if you're not able to generate that bucket of, your pituitary gland senses that and tells your thyroid to make more hormone, and that message is thyroid stimulating hormone, or the TSH. And if the TSH is going up but the factory is damaged, then it can't generate that hormone. And that is why we end up supplementing that bucket with extra thyroid hormone, so that whatever minimum will keep your TSH normal. And the other mistake, what people end up doing is, the moment their TSH comes back to normal, they stop their thyroid hormone. And that is why I need to give them that heads up, that if you ate yesterday, that doesn't mean that you will be not hungry today. So it's the same thing for the thyroids, that if you are well controlled on medications, that's because you took the medication. The minute you're going to stop it, in a month it might be 6, in 10, in 3 months it might be 12, it might be 20, whatever, it's going to go up. So I think that's, once you explain and clear a lot of these misconceptions, I don't think people make those mistakes with it.
And who should watch out for hypothyroidism? Like, are there any risk factors one should be aware of?
I think the most commonest risk factor really is a family history of thyroid problem, because it's starting to get so common. Now the question is, profound overt hypothyroidism is probably still rare. What we're really really calling hypothyroidism today is subclinical hypothyroidism, where by definition it's a biochemical diagnosis really, and patients are really not symptomatic, and it's sort of more a lab finding than a clinical finding. But yes, in the subset of patients who have a family history of thyroid, which is, then my index of suspicion would be higher to screen them. If they have symptoms, like patients come to me and say, I have thyroid, should I test my child? So I usually tell them that, if they are symptomatic, maybe definitely checking it once is okay, or if something changes, then go ahead and test it. But otherwise, there's no clear guidelines that just because you should keep every year, you should check a thyroid function. That is not standard of care as of now.
Now, just sort of going back to the place where we started, overdiagnosing and hypothyroidism or thyroid disorder is extremely common. How do you think we as professionals, or as clinicians or public health professionals, how do we tackle this?
So I think it, as doctors, we can create fear, or we can calm. And I think it comes back to education, and what is the motive of the education. Having a heart disease, developing nephropathy, having diabetes, definitely things which need to be counseled about, explained about, stuff like that. Yes, we can say something like a thyroid disease is important to be treated and stuff like that, but it's not, in the large scheme of things, nobody's going to drop dead in a day. And it's something that you can monitor, you can see which way it's going, and you have time to intervene. So I think, as a health professional, I think the message that goes out to the public in terms of what is it that needs to be done, what is important, what is less important, what is it that you can do something about. So there are certain things. See, as far as the thyroid, patients often ask me, what can I do differently? Is it something I ate? Is it something I did? Is it all kinds of doubts in their minds. And unfortunately, there are nothing that they did or they could do differently that will change the course of their thyroid disease. Diabetes, coronary artery disease, all these things are slightly different, because you may be able to change the trajectory of your disease.
Yeah.
But this is not something which is really in their hands. It's really, if you have something, I can treat you for that. But I cannot pick you up early and change you, and say I have somebody who comes to me with very high titers of thyroid antibodies, say 1,000, and people freak out when, because they see anything more than 1,000, they're scared. And their TSH is 2, but there's nothing for me to do. And studies have shown that in the past, when they've been treated with steroids, it has not shown to change disease progression. So then what is the point of doing something? So I just reassure and I can explain that this is the course of things. all the antibody positivity means is that you are at a higher likelihood of developing permanent hypothyroidism than somebody in the general population. So maybe keep an eye out. If you have symptoms, check a TSH. And if it's abnormal, come and see me again.
Yeah. So we've been sort of talking for almost half an hour now, and just to sort of summarize the entire discussion, the most important point that, two things I feel are like starkly coming out. One is that getting diagnosed early is only useful if you follow it up with some lifestyle modification.
Absolutely.
Otherwise, just doing tests all the time and not doing anything about it is pointless. The other thing that is coming out is that doctors play a very important role. Firstly, in educating people, and second thing, they should sort of tell everybody what the red flags really are. Whenever somebody comes with some doubt, some complaint, it's important to not just tell them that this is normal, but also tell them, when actually the problem is. So those are two very important messages, I feel, besides, a lot of other things that we have talked about.
Now, the thing part is that, see, I agree that when you look at, say, a country like India, where healthcare is so disparate, where there are doctors there who are looking at 300 patients a day, where it is probably difficult to do that. And say there are people who are seeing, say, 30 patients or 70, 80 patients per day, which probably might be a larger portion of India, but we'll still have to create those mechanisms, because what easy things you can do is maybe, at, say, if you have a huge waiting area, you can run reels of things which are public education things, or have little group education
Or they
classes.
can play this podcast.
Yeah, I mean, I'm just saying, there is today with technology, there are so many things we can do to ease the burden of these, people who are so, busy. Because I think, but when it comes from the doctor, the patient actually values it. You might speak for 2 minutes, but when it actually is their words, the patient, whether it be diet, whether it be exercise, outsourcing that is one thing, but when it comes from your mouth, I usually write my lifestyle changes on their prescription in my own handwriting. And when they do a good job, I say, great, good job, put a star or something. So they feel very happy about it. So, I mean, I'm just saying, they're very little things. It doesn't take much. We are all like little kids. We all like to do well.
And our system has sort of
And
given us,
something,
yeah, our education system always, wants us to get those stars.
yes, marks and stuff. So I have elderly patients who look at their spouses and say, "See, doctor said I'm doing great." So
I
I
got
mean,
one star
it's
more
like
than
little.
you.
I have husbands and wives who come in and show me their HbA1cs.
Yeah. No, when you make it a competition between husband and wife, I'm sure, the outcome will be much better.
No, but when you do it as a family, it just is much more sustainable. They go for walks together, they eat the same things. So
Mm.
my mother is a diabetic. So my dad, years ago, he decided to stop sugar. So to just give her company. So, but I think that went a long way, because you don't feel like, I am the only lone one out there, and you become a victim
Yeah.
mindset. But you're just doing it together, and it's just nothing wrong about it. It's just much more
Yeah.
better way if you can do it. That's great.
So, that's a really nice suggestion. So, sort of to conclude this entire discussion, if you have worked like probably you are my age is what your clinical experience is, maybe more than that. But if there was one aspect of public health in India that if you had the power, that's something you would want to fix, what would that be?
I think really, our target of intervention should be pregnant mothers. This is something I've really felt over the years, because pregnant mothers are very receptive. They're very obedient. They listen. They're all ears.
Hmm.
That's a great window of opportunity, because you're changing two lives with one.
Yeah.
Every time I get a GDM mother, I'm spending a little extra time, trying to change. Because if you can get to that woman, she'll take care of her family, and we can, grow out. We look outward in, but we start inward out. I think we'll do better if the mother is healthy, the intrauterine environment is healthy. Childhood will be healthier. The puberty is going to be better. PCOD will be lesser. It's the infertility will be lesser. I mean, I just feel the earliest primordial intervention is in the womb.
Yeah. No. Yeah. Yeah. So something recently came out as well. The womb training and all that. Yeah. Maybe you could apply it in public health with educating mothers as well.
Okay.
Yeah. So educating mothers, and that's actually very practical and a very important suggestion. And I hope
I
this
think
will
it's
be
just
somehow.
easier.
Yeah.
I think it's easier because I think increasingly women are seeking healthcare for pregnancies, even it be whatever setting they are in. And I think if we can catch them at that point and handhold them through things, I think a motivated mother will take care of the family, is what I
Yeah.
feel.
So before we close, any one-line suggestion for any healthcare worker who's watching this?
I think you're doing a fantastic job. It's not easy being in healthcare today. Every day may not be a day where you might get a thanks or appreciation from anybody. But there will be that one patient who says, "Thank God, doc, you exist," and that will make your day. And I think it makes it all worth it.
So thanks a lot, Sona ma'am, for taking out the time for this. And
You're
I
welcome.
hope people who are watching this have learned something today. And I will
Thank you.
share this link with you as well, so that you can spread it. Maybe the patients can start watching this now. I will save some time. But thanks again for this, and I hope this reaches out to the target audience and they learn something. And maybe with this, at least if we can stop some small percentage of overdiagnosis, I think I'd be happy with that.
I agree. Thank you, Parth. Thanks for doing this.
Uh,
Keep up the good job.
Thanks a lot.